Good morning and welcome to the Chamber of Commerce Southern New Jersey's virtual Health Issues Committee meeting. My name is Hillary Chebra. I'm the Manager of Government Affairs for the Chamber, and it is my pleasure to welcome all who have logged on to join us today. Thank you for being here. I'm extremely grateful to today's guests, Kevin Lucia, a research professor, founder, and co-director at the Center of Health Insurance Reforms, and Jack Hoadley, research professor emeritus at Health Policy Institute of Georgetown University's McCourt School of Public Policy, who will discuss their research on the new federal surprise billing law. We'll be hearing from them both momentarily, but I want to thank them in advance for being with us today. Thank you. Before we begin, as always, I'll start by thanking our sponsors, starting with Horizon Blue Cross Blue Shield, the Chamber's Government Action Series sponsor, and our Health Issues Committee sponsors, AmeriHealth New Jersey, Fox Rothschild LLP, Inspira Health, Samaritan Health Enhancing Care, and We Work for Health. Thank you all for your generous support of the Chamber's programming as we continue to conduct events online, and we look forward to returning to events in person later this year. So now it's my pleasure to turn the virtual platform over to Ward Sanders, the president of the New Jersey Association of Health Plans and chair of the Chamber's Health Issues Committee. Ward, the floor is yours.
I really appreciate that, and good morning, everyone. Really pleased this morning to be virtually hosting Kevin and Jack, who will discuss their research on the new federal surprise billing law and its effect on similar New Jersey legislation. And so both of you, thank you for taking time to speak with us this morning. We look forward to hearing from you momentarily. A few housekeeping items before we begin. In a moment, I'll formally introduce Kevin and Jack and turn the floor over to them for their opening remarks. Once they conclude, I'm going to call on one payer and one facility for some initial reactions and thoughts about the federal and state surprise billing laws. Then I'll pose questions received from members. The chat feature is now open and will be open the entire program. So if you have questions for our presenters, please feel free to answer them at any time. If after the event you have a follow-up question, comments, or thoughts, feel free to align them on the survey that will be emailed to you. Our online events will not be much different than our in-person events. You'll receive a survey after we conclude. I would love for you to hear, would love to hear your feedback on today's program and follow items that you have. So it's my pleasure to introduce today's guest. First, we'll start with Kevin. Kevin is a research professor, founder, and co-director of the Center for Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. There he directs research and analysis of federal and state laws related to access, affordability, and adequacy of provider health insurance. He's authored numerous reports, issue briefs, and blog posts relating to the regulation of private health insurance and health insurance marketplaces, and is frequently quoted in the media. He informs state and federal policymakers, insurance regulators, and health insurance stakeholders, and has been supported by government, private foundation, and various stakeholder organizations. He returned to Georgetown University in 2011 after directing the State Compliance Division. It's in the Office of Oversight for the Center for Consumer Information and Insurance Oversight at CMS. From 2011 to 2016, he served as executive board member and chair of the Insurance Market Committee of the Health Benefit Exchange Authority for the District of Columbia, and he holds his JD from George Washington University School of Law and an MHP from Northeastern University. So welcome, Kevin. Thank you for being here today. With him is his colleague, Jack Hoadley. Jack is a research professor emeritus. Emeritus means that you have special gravitas in the world. He in the Health Policy Institute of Georgetown University's McCourt School of Public Policy. He retired in 2017, but continues to conduct research on a part-time basis. In over 35 years as a health policy researcher, he studied a wide range of health financing topics, focusing on Medicare, Medicaid, and private health insurance. His main area of research currently is state and federal consumer protection laws around surprise billings, our topic today. Other recent papers have addressed Medicare Part B drug benefits, access, costs, and coverage for prescription drugs, Medicaid coverage for children and families in small towns and rural areas, and the impact of provider concentration. He is served for 6 years as a commissioner on the MedPAC, Medicare Payment Advisory Commission. And from 2012 to 2018, he holds a PhD in political science. Prior to arriving at Georgetown in 2002, he held staff positions at the Department of Health and Human Services, MedPAC, the Physician Payment Review Commission, and the National Health Policy Forum. Just on a personal note, I've been an acquaintance and fan of the folks in Georgetown since my time as a former regulator. Their scholarly work on practical issues facing consumers / patients in healthcare is really to be commended. So if you're not familiar with your work, you should do so. They do some great work. So both of you, thank you for taking the time out of your busy schedules. And now I will pass off the floor to Kevin.
Great, thank you. Thanks so much for that nice introduction and of course the invite to join the meeting today. We're really looking forward to running through these slides quickly and then the discussion and hopefully some time for questions and answers. We can go on to slide number 2. So as mentioned, we are faculty with the Center on Health Insurance Reform, which is part of the McCourt School of Public Policy at Georgetown. Our primary focus is private health insurance and healthcare reform. For the last 15 years, Jack and I have monitored and analyzed balanced billing protections among the states, and more recently engaged in the policy discussion at the federal level, which at times was pretty intense, as you know. Just want to give a call out to our website at Georgetown on the slide, and also our primary funders on our balanced billing research, which includes the Commonwealth Fund, the Arnold Foundation, and Robert Wood Johnson Foundation. We can move on to slide number 3. So we know that many of you are familiar with balanced billing, especially here in New Jersey, one of the states to pass comprehensive law to protect consumers from balanced billing. We understand it was a long haul to get that done. For those of you that are on the call that are new to this issue, a quick introduction to the concept of balanced billing. Balanced bills arise when insurance covers out-of-network care, but the provider bills the consumer for amounts beyond what the issuer pays and beyond cost sharing, as well as in situations where the out-of-network care is not normally covered, but the selection of the provider is outside the consumer's control. In some cases, it's been documented that enrollees face thousands of dollars in charges and referred to as balanced bills above the expected cost sharing. Balanced billing is primarily a result from interactions with providers that the patients reasonably assume would not be in the network, but would be in the network, but were not, or when patients have no real choice in a provider. Consumers are most likely to receive surprise medical bills from health providers outside their insurance plan's network after receiving emergency care or medical procedures at in-network facilities. In the latter cases, for example, consumers may select a surgeon and facility that's in-network, but discover that other providers, such as an anesthesiologist or surgical assistants, are out-of-network. It can also happen with ambulance, both ground and air services. If we can go on to slide number 4, please. Of course, the actual incidence of balanced billing is unclear because most data sources do not capture whether providers send their patients balanced bills or seek to collect them. But we know that many consumers are at risk for being balanced billed because they use out-of-network providers. Research has found that 14% of emergency department visits were likely to produce a surprise bill, as were 9% of hospital stays. The risk is even greater for patients admitted to the hospital through the emergency department. 20% of such patients were likely to receive a surprise bill. You can see the risk of being balanced billed on this chart is higher following a ground or ambulance, air ambulance service flights. Slide number 5, please. States have recognized the need to protect consumers from balanced billing. In 2020 alone, we saw Georgia, Maine, Michigan, and Virginia pass comprehensive protections on an overwhelmingly bipartisan basis, making a total of 18 states, including New Jersey, with comprehensive protections to bar surprise medical bills in emergency and non-emergency situations. But as you know, state laws can only go so far, including not being able to require the application of balanced billing protections to self-funded plans or providers of air ambulance services. Now, we know that in New Jersey, you have a self-funded opt-in, but we're really talking about making, the requirement that self-funded plans, protect people from balanced billing, and that is outside the reach of states. Slide number 6, please. So Congress included the No Surprises Act in a spending bill that was passed and signed into law by President Trump on December 27, 2020. This new bipartisan bicameral legislation is the culmination of 2 years of hearings, markups, campaign ads, which a lot of money was spent to push the debate. And then, of course, negotiations. Congress had gotten close before, but up until the No Surprises Act was not really able to get across the line. It was really a last-minute push that was successful and surprising, to be honest with you. In setting a national federal floor for the first time, it brings protections from balance billing into many of the most at-risk situations that we talked about a minute ago. It's extremely helpful for those that are covered under fully insured plans in states that don't have their own balance billing laws, which there are a lot of them, and for the nearly 135 million in self-funded plans beyond the reach of state laws. I do need to note that in the analysis of the No Surprises Act presented in the next set of slides, this is just based on our best reading by the Georgetown team. And of course, the federal rulemaking process may reach to different conclusions. So this is, we do have a number of pieces that are out there, circulating that analyze the bill, and the feedback has generally been pretty consistent that it's right. And so we'll share those resources at the end, but who knows what will happen during the federal rulemaking process. As you know, things can change and be interpreted differently depending on dependent on the federal analysis. So if we can move on to slide number 7, please. The No Surprises Act applies to enrollees in self-funded plans and group and individual health insurance coverage offered by health insurance issuers, so marketplaces. The law also applies to grandfathered health plans. It doesn't apply to short-term limited duration plans. I'm not even sure if New Jersey has those, but it also doesn't apply to accepted benefits such as standalone dental or vision plans or cancer-only policies. Consumers will be protected from surprise medical bills when they receive care in both the emergency and non-emergency setting, the latter being at network facilities. The protections extend to out-of-network air ambulances. Protections also apply to post-stabilization services until the patient can travel without using non-medical or non-emergency medical transportation. As a result, patients will be protected from surprise bills in many of the situations where they have little or no control over who provides their care. It's important to note that the legislation does not extend balance billing protections to ground ambulances, although there is a study committee to make recommendations that is empowered by the Act. If we can go on to slide number 8, please. Enrollees who see an out-of-network provider will not be responsible for cost sharing other than what they would have paid to an in-network provider. Their co-insurance will be based on what the term they use is recognized amount, generally the median in-network rate, or the amount determined under state law if a state has a law that is recognized. Any cost sharing payments made by them will count towards their in-network deductible and in-network out-of-pocket limit. Equally important to the above, out-of-network providers will be barred from sending or collecting a bill for amounts other than in-network cost sharing. Slide number 9. The Act doesn't include a benchmark or standard for determination of an out-of-network payment rates for payments from health plans to out-of-network providers or facilities. It provides instead for such a rate to be determined through open negotiations, and then if that fails, through independent dispute resolution. That said, the Act provides a deference to state laws with what they call it a specified state law, and that's a law that includes a method for determining the payment. The state method applies for the health plans regulated by the state and for the services to which the state law applies. The state method is likely to apply in 18 states with comprehensive surprise billing laws, including New Jersey, and in several states with partial protections for applicable services. So there's some states out there that have these partial protections for balance billing, and maybe they have a payment method that's been designated. For other states in self-funded plans, the federal method applies, In addition, for services not regulated by the states, such as air ambulances, the federal method applies to. Our base read is that it would apply across the board to self-funded plans. So, there's a question on whether states that have self-funded opt-in programs will survive. But I think that we'll learn more during the reg writing process. Can we move to slide number 10, please? The legislation establishes timeframes for the arbitration process and imposes other guardrails. For instance, issuers and providers will have 30 days to engage in private voluntary negotiations to try to resolve the payment dispute. If negotiations fail, either party may, within 4 days, request independent dispute resolution. Presumably, if there's no settlement and no request for arbitration, the provider will accept the amount paid by the issuer. The arbitration process will be administered by independent dispute resolution entities that are subject to conflict of interest standards. The federal government will establish the independent dispute resolution process, which includes a list of entities available to take cases. The Act adopts baseball-style arbitration rules, which you're familiar with. Each party offers a payment amount, and the arbiter selects one amount or the other with no ability to split the difference. The decision is then binding on the parties, although the parties can continue to negotiate or settle through the process. Multiple cases can be batched together in a single arbitration proceeding to encourage efficiency, but those batch cases must involve the same provider or facility, the same issuer, treatment of the same or similar medical condition, and have to occur within a single 30-day period. It makes your head spin a little bit. So I think we're going to learn a lot more about how that plays out during reg writing too. I just want to call your attention to 2 rules that can help deter overuse of the IDR process. First, the losing party will be responsible for paying the administrative cost of arbitration, which will be set by the secretary. This rule increases the financial stakes for pursuing long shot cases. Second, the party that initiates the arbitration process is basically locked out from taking the same party to arbitration for the same item or service for 90 days following a decision. The goal of this provision is to encourage settlements of similar claims. Any claims that occur during the lockout period, however, can then go to arbitration after that period ends. If we can go to slide number 11, please. Arbitrators will have flexibility to consider a range of factors. This includes any relevant factors raised by the parties, but not the provider's usual and customary charge or the bill charge. By explicitly prohibiting arbiters from considering provider charges, the legislation attempts to help limit any potential inflationary effects if arbitration leads to settlements well above the amount issuers pay to in-network providers. On the other side, arbiters cannot consider the reinsurance rates paid by public payers such as Medicare, Medicaid, CHIP, and TRICARE. Optional factors that an arbiter can consider are many. For example, the quality and outcome measures of the provider or facility, the market share held by the out-of-network healthcare provider or facility. There's others that are listed on the slide. Arbiters are specifically directed to consider the median in-network rate paid by the issuer. And federal officials in implementing the dispute resolution process might opt to provide more guidance on the use of this factor and other factors that we have listed. The same general factors apply to air ambulance providers with some adjustments such as location, where the patient was picked up, and the population density of that location, and the air ambulance vehicle type and medical capabilities. If we can go to slide number 12, please. The Act allows for some voluntary exceptions to surprise medical bill protections, but only if a patient knowingly and voluntarily agrees to use an out-of-network provider. For example, if a patient wants to select an out-of-network orthopedist for a knee replacement or an out-of-network OBGYN for a scheduled delivery, the patient can waive the federal protections, and thus could be, balance billing could be opposed. Because the patient is knowingly choosing to see an out-of-network provider, the reasoning goes that the additional cost is no longer a surprise to the patient. The legislation also allows certain providers to request that a patient sign a consent waiver, but this exception is relatively narrow and generally more protective of consumers than state laws that allow for consent waivers. This exception is not allowed in non-emergency situations. I'm sorry, it's only allowed in non-emergency situations. You can't do it if there's an emergency situation. And the providers may not request a consent waiver if there is no in-network provider available in the facility, the care is for unforeseen or urgent services, and the provider is an ancillary provider that the patient typically does not select, like a radiologist or anesthesiologist. The legislation identifies a list of providers that may not ask for a consent waiver, and the federal officials will be able to identify additional providers in future rulemaking. For providers that are eligible to ask a patient for a consent waiver, the provider must generally notify the consumer in writing 72 hours before the service is scheduled to be delivered. This notification must include a good faith estimate of cost and identify available in-network options for obtaining the service, so the patient can see, that there are network providers available for them to go to. If we could go to slide number 13. With respect to issuers and employers, the Act adopts the same enforcement framework as the ACA and HIPAA regulates silence. Fashion allows states to require a provider, including ambulances, to comply with the new standards. If a state fails to substantially enforce these requirements, the federal government will step in and do so. The federal backup enforcement will allow the federal government to impose civil monetary penalties against providers for up to $10,000 per violation. And federal officials must also establish a process to receive consumer complaints on surprise medical bills. We expect that many states will step up and enforce the standards against providers and facilities. When they do, they might follow other states that have comprehensive balanced billing protections in place. It's been a challenging, the enforcement against providers has been challenging in some of the states, but sometimes they've used the insurance department, the health department, medical licensing entity, the Consumer Protection Agency or the AG, or kind of a blended approach. I can think of a state that the DOI kind of gets complaints. They look for trends. They actually reach out to providers and says, to say like, you can't balance bill in this situation. And then if there's an ongoing trend, it gets referred to, I believe, the medical licensing entity, and then in collaboration with the AG. So there may be blended approaches that states take on. But again, if the state doesn't want to enforce against providers, I think the feds are required to. I'm actually curious to see how New Jersey enforces these protections against providers, and hoping someone will bring that up in the discussion. Slide number 15, please. There's a significant amount of data collection, reporting, and analysis required under the Act. This includes extensive reporting of detailed information on our.
You could jump 2 more slides ahead. Back 1.
Oh,
sorry. Go ahead, Kevin.
This is the reporting one. Yeah. Yep, perfect. This there's a significant amount of data collection, reporting, and analysis required under the Act. This includes extensive reporting of detailed information on arbitration outcomes, including the final amount as a percentage of median in-network rates. In addition, there are numerous required studies related to the impact of the Act. HHS, for instance, must report on the legislation's impact on factors such as provider consolidation, healthcare costs, and access to rural areas. GAO has a number of reports, and there's significant reporting on cost reporting on air ambulances, and then an advisory committee that will focus on quality and payment safety recommendations for Congress. We can go on to the next slide, please. So in general, when we're thinking about states, the No Surprises Act follows the preemption standard under HIPAA and the ACA. So state laws that do not meet the federal minimum standard will be preempted. But if a state has a more, protective, but in the situation of a state having something more protective, as long as they don't prevent the application of federal law, it'll survive. So for example, a state balanced billing law that requires providers who are eligible to ask a patient for a consent waiver to notify the consumer in writing, say in 7 days versus the 72 hours under the NSA before services are scheduled to deliver, that would probably survive preemption. So you just kind of think about the same framework that we have watched the ACA be implemented. It's important to note that the No Surprises Act explicitly defers to states on provider directory requirements. So that's one of the provisions that kind of fall out of that general framing on enforcement, on preemption. Since the legislation has no provisions applying protections in certain areas such as ground ambulances or short-term plans, there's an opportunity for states to continue to fill in the blanks. Slide number 17, just want to call out, and I know we're not going to be talking about these today, but there's a number of other protections that are in the act that are related to surprise medical bills. Continuity of care protections, provider directories, as we just mentioned. There's requirements regarding advanced explanation of benefits, and just want to call out that for for an uninsured patient, they can take advantage of that advanced EOB, and if they end up not getting their costs become substantially higher than the good faith estimate that they received from the provider, they can go to a separately set up independent dispute resolution process that's going to be run by HHS, or we think will be run by HHS. Slide 18, please. Okay, and then just to call out that there is funding for states to set up or improve an existing state all-payer claims database. It also requires, which I think is important for states that have these, that no later than 1 year after enactment to establish a standardized format for reporting by self-insured group health plans for state APCDs on medical claims, pharmacy claims, dental claims, and eligibility and provider files. And provides guidance to states on the process for collecting such data in a standardized reporting format. But it doesn't allow the states to require self-funded plans to report. It doesn't go so far, but it does start the process of making sure that there's a uniform standardized form to collect that data. And actually the secretary can prioritize funding applications, for these grants that will be used, provided that they agree to use the reporting format. Slide number 19, please. Okay, so federal rulemaking will generally involve HHS, Labor, Treasury, so tri-agency. Department of Transportation will be pulled in for air ambulances. It's really fast moving. The law has early deadlines in the notice and consent forms, July 1, I think. The methodology for the qualifying payment amount, July 1. The audit system for the qualifying payment amount, October 1st. Otherwise, rulemaking simply needs to be ready by the 2022 effective date. And we're assuming that the agencies have started work on this, but the truth is, at least from media reports, not all the political appointees are in place, right? And so that there may be some work taking place, but what might slow this process down is that the decision makers are not necessarily in place yet. So the agencies are going to have a ton of work to do to implement this bill, very fast moving. And I guess the last just slide is if we can go to the last one, which is just our resources. I really just want to wrap up by calling out a number of resources we have available on balanced billing. The No Surprises Act. First, we maintain a balanced billing information center, which is basically a one-stop resource center on balanced billing. And it's been updated for the No Surprises Act. So it has all of our resources, but it also has everything that's coming out of other organizations like any analysis coming out of Brookings or any other analytical analysis that's out there. It's pretty extensive, and we try to keep it up to base. I think it can be helpful if you want to get your head around this issue. We also maintain an interactive map of state balance billing laws, which is housed on the Commonwealth Fund's website. It's basically a deep dive on states with partial and comprehensive balance billing laws. So you can kind of compare New Jersey to other states. And then, at some point you'll be able to kind of compare what states have compared to the NSA. And then finally, we have a number of resources available just on the No Surprises Act. The first is an overview of the new legislation for the Commonwealth Fund. It also includes a link to a very detailed summary of the act that Jack, who's going to be joining for Q&As and may have some comments after my presentation, is co-authored. So we're glad to have him on the call to take some of these very detailed questions that might come in. And then the second is a write-up that we did for Health Affairs blog. It's more than a blog post. It really kind of walks you through basically the entire act. So that's it for me. Jack, I don't know if you want to just if there's anything you want to say or clarify before we hand it back to Ward.
No, I'll wait for the Q&A. Thanks, Kevin.
Yeah. Thank you.
Okay, I hit were the right buttons there. That was great, Kevin and Jack. Thank you so much for this. I had a connection problem a little bit. I heard, am I coming through okay, Kevin or Jack?
Yeah, you're good.
Okay. So thank you very much for that. It was a great overview. This is really a story of the healthcare system kind of failing consumers / patients, just through no fault of their own, trying to navigate the healthcare system, people getting walloped with huge bills, obviously not a good outcome. So these state and federal efforts are important. And a long time coming. Normally we do have the chat feature open, so and we have some questions, keep those questions coming. We're going to try something a little bit differently. We're going to have a reactor panel. So if I could elevate, and I just sprung this on the South Jersey folks, but when we start with Peter Caprellian from Inspira Health, and we'll try to elevate him. Hopefully he does not appear as a cat on this when he comes up. There he is. He's on his way here. So Peter, again, is with Inspira Health, and I've asked him to talk a little bit about the facility experience under New Jersey law and questions, or thoughts about the new federal law. So Peter, you have the floor for, 2 to 5 minutes or so, and I really appreciate your help.
Yes, I have a PowerPoint presentation I'd like to throw up. No, not really. Thank you. That's a tough act to follow. And at the onset, I don't know, Ward, you referred to me as a facility. So, but Inspira Health is three acute care hospitals in South Jersey. In one county, Cumberland County, we are the sole acute care provider. And I certainly appreciate the presentation, especially Kevin, your words. I'm speaking as a government relations officer, so you have to factor in a little bit what I have to say, if you will. But we do dabble in policy discussions, and this is kind of a healthcare policy wonk dream come true, I guess, as we try to work on this. Is not the first time that healthcare has been tried to be addressed and modified. But what I'd like to do is just give you my boots on the ground reaction, if you will, based upon the impact of the New Jersey out-of-network law, which we think is kind of the precursor to what we might expect from the federal law. And Kevin, you said something very important. There is a wild card in all of this, and that is the rulemaking process, right? So the devil's in the details, and that's really where our concerns are, is that we really feel that we're going to need a lot more clarity on these issues, and we don't have a quick ramp up time. I mean, if to your point, if it were to come out in mid-year, and some of the issues don't even come out until the actual law, until it takes effect, it's going to be difficult for us to be prepared for that. And hopefully there will be some sort of glide path, perhaps. But to your point, until everybody's in place, it's tough to figure out what's going to happen. So first of all, let me just say we are very much in favor, and all providers are in favor of patient protection. Certainly. In the final analysis, we're all healthcare consumers, and we're a patient somewhere in the continuum. our issue really is the other part of this that has to do with, and this really started in New Jersey, I guess, if you will. And it's unknown what the federal impact is going to be, is how providers and payers interact. And the moment that you start to, in our mind, that was not a problem. It created a problem where one did not exist. And in the New Jersey experience, it essentially, out-of-network law was really designed to address one bad actor who used egregious out-of-network policy for their bottom line. In our case, and we have, I feel we have a healthy relationship with the New Jersey-based payers. I just want to be clear about that. But what happened was, with a national payer, when the out-of-network law went into effect in 2018, immediately their demand was a significant cut in contract rates, and we believe it's as a result of the New Jersey out-of-network law. And the challenge was, in our case, they essentially said, well, if it's take it or leave it. And but they didn't have any appreciation for what the plight of the consumer was for the next the next in-network payer was probably, I don't know, a good 45 to an hour minutes away, going from, for those in the area, going from Vineland to Cherry Hill, as if that's a hop, skip, and a jump. And so they showed lack of appreciation of the plight of the patient, I think. And so that was a concern that we have, was that we feel that the leverage has shifted from the provider to the insurance company. And that's the concern, one of the concerns that we have with where the federal law will go. It's all about unintended consequences. Perhaps in New Jersey, the larger health systems, they may have that too big to fail kind of attitude. But for the smaller providers, I think the concern is that they lose leverage, and then you result in perhaps mergers and consolidation. And there's a lot of debate about what that does to healthcare costs. But in certain regard, the concern is that it forces these smaller providers to merge with larger organizations. So I know that's a bit of a worst case scenario, but it's one of the unintended consequences that we have concerns about for where the federal, what the details would go. I will say we also have challenges with implementation. I would not underestimate what it's going to take to prepare a good faith estimate. This is really virgin territory of providers and insurers coming together and try to put together cohesive information for the patient in a timely manner. I mean, I'm not sure what it's going to take to make that happen. And so, I don't want to speak for the insurers, for the payers, but I have to think that getting to the point where everybody's comfortable with, here's an advanced explanation of your benefit, that's a real hurdle that's going to take some coordination that we really have not done before. In New Jersey, the provider provides the estimate, and it's based upon what we feel it could look like. But this is just it's going to be a real challenge. The consumer deserves it, don't get me wrong. It's just we're going to need more than 6 months to try to figure out how to work together in this process. So that's really our concern, is trying to be prepared when the rules come out, that we can work together for the best interest of the consumer. So I'll kind of stop there. It's, again, bottom line is we really need clarity to be able to better assess how we move forward with this.
That's great, Peter. Thank you for those thoughtful comments and on the impact here. And now, and we'll elevate Jill Squires from AmeriHealth for our payer perspective. So if the good folks at the South Jersey Chamber could elevate Jill, and then we'll hear the payer perspective for a couple minutes and then go through some of the questions. Reminder again that the chat box is open. We do have some questions for our panelists. I have some other questions too. But keep those questions coming. And there is Jill, as if she were in Trenton, New Jersey. There we go. Yeah.
Thanks. And I appreciate Peter's recognition that the advanced DOB is going to be a hurdle. We too believe that that is going to be a hurdle. And although patients and our members absolutely should know in advance what the cost of their services will be, as Peter identified, that is going to be a challenge to implement over the next several months. I had two main takeaways from the discussion. One is that because in New Jersey, the out-of-network law is simply an opt-in for the self-funded plans, what I believe is going to happen is providers will now have a bifurcated process where the federal law is going to apply to the self-funded plans and how the out-of-network negotiation and arbitration should work for self-funded, whereas the New Jersey law is going to apply to the fully funded plan. So providers, although they will know if a member is covered by a self-funded plan or a fully insured plan, the providers now are going to have two different types of negotiation and arbitration paths to go down. They've become familiar now with the New Jersey process, and now they will have to learn another process for the self-funded members. So I do think that's going to be a challenge for providers. One of the other things that I took away from the discussion was related to preemption. So for example, the slide where you talk about the specified state law and how payment for out-of-network care is determined by the or it may defer to the specified state law. In New Jersey, we don't specify how that payment is supposed to work. We don't specify the method for reimbursement of out-of-network claims. So what I'm wondering is, because we don't specify that, will the No Surprises Act preempt New Jersey with respect to reimbursing out-of-network claims? I don't know if the Georgetown team has an answer about whether the preemption may be piecemeal, because one of the other things I'm also interested in is the advisory committee for the ground ambulance. I think the New Jersey out-of-network law has made great strides in protecting members and smoothing the way for providers and payers to come to terms with reimbursement for out-of-network claims. But the ambulance is a big mess, and that is still an area of risk for members and the providers' patients. So if in fact that ground ambulance does become part of the federal law, because New Jersey law does not address it, would that now be something that both self-funded and fully insured payers would be able to respond to? So I do have some preemption questions.
That's terrific, Jill. Thank you for your comments. Just to Kevin and Jack, I don't know if you have any initial reactions that you want to offer. Peter's points of the collateral impact on negotiated rates of the model, and so the need for regulatory and a glide path. And Jill's point. Any comments or immediate reactions from you before we go to the chat box?
Yeah, I sent Peter a text saying great insights, because I think that's what we're hearing. It's a lot has to happen in a very short amount of time, and we're hearing that both from on the provider side and on the issuer side. And I think that the federal regulators are. It's a time of a lot of work has to get done during the transition. There's a lot of else that's going on at the federal level, in this next COVID package. And there's capacity issues to handle all this stuff. But on the other hand, they've been working. I feel like we've seen the feds work really quickly, and it'll be interesting to kind of see what they, where they land and how fast they move. But what you said, Peter, and actually Jill too, like we're hearing that across the board from stakeholders as we talk to folks nationwide. Jill, on your specific question about the specified state law, I think that so the arbitration process, as far as we are concerned, like our analysis would suggest that would count So where New Jersey would land would become would still, like, the federal law would still give deference to that approach as far as and maintain it as far as the fully insured market. But you're right, it wouldn't apply to the self-funded market. So you're going to have these two systems that play out. I mean, some states are contemplating what they're going to do. Do they want to have one? Do they just want to adopt the federal standards, or do they want to maintain their state payment standard for their fully insured market? It's certainly going to add a lot of confusions, not just for providers, but issuers and also consumers, to know exactly what their protection is. On the other hand, at least for states that have comprehensive balanced billing protections and now with this federal bill, consumers are generally kind of taken out of the picture, so they shouldn't be balanced billed, at least in the areas that have been kind of focused on. So that's one, for consumers, it's across the board, they should be pulled out. But I think you're right. It's going to be complicated for other stakeholders to kind of navigate these different rules, and states may end up wanting to modify their law to kind of become more uniform. We'd be interested to hear if you think New Jersey will ultimately do that. Jack, do you want to jump in?
Yeah, just to add that I think everything you said is right. There are some states that have payment mechanism, payment rules, maybe a prompt payment requirement that requires something, say an emergency situation similar to the old federal requirement for the greatest of three rates to be paid in emergency. If a state has codified that rule, one of the open questions is whether that would be deferred to. But we do think, based on our read, that for all the states with comprehensive laws that have an arbitration system or have a combination of a rate standard with an appeal to arbitration, or even just a rate standard, that those should serve as the payment mechanism for the state regulated segment of the market. But there will be a process undoubtedly by the three agencies, probably mostly by HHS, to take a look at each state law and indicate whether it meets the requirement of that specified state law. Yeah, I see Peter wants to jump in.
Well, I think,
sorry.
Jack, you mentioned a great part. You said actually codify. I think in New Jersey, we just have guidance right now. Right, not even the rules. We just have guidance. And so I don't know, I think ultimately, and I think Jill is touching on this, how will federal law intersect with the state laws is a big unknown, and especially since we don't have the codification, if that's the right descriptor of that. So I think that'll be a challenge as well.
Yeah, that's one of the things certainly that's crossed my mind is that, I don't think we can think of this as a preemption of New Jersey law or non-preemption. It may be very fact specific, if I understood your comments, Kevin, correctly, which is to say that if New Jersey has addressed like air ambulance is not covered under New Jersey law, I don't think, but it is under the federal law. So this prevent the application standard in the federal law may mean that New Jersey law prevails in most cases, but with respect to air ambulances, I presume that there'll be points at which the federal law would preempt state law if essentially if the consumer isn't advantaged by any kind of state protections.
Yeah, I think that's
example
of
that in
I'm sorry, go
Washington
ahead.
State. I'm sorry, Kevin.
No, sorry, go ahead. Yeah.
Example in Washington State, where their law for non-emergency situations is limited to certain specialties. So their law applies to anesthesia, radiology, but it does not apply to neonatology, or does not apply to surgery. And so they're already thinking that they may need to add those in so that you don't have the situation that's even more bifurcated than Jill's example. It's not just whether it's self-insured or fully insured, but even if you're fully insured, if it's the neonatologist, there's the federal law would apply, but if it's the anesthesiologist, the state law would apply. And so they're already thinking that they need to do some adjustment to their law to do that. So I think we're going to see a lot of these conversations about how to keep the system as consistent as possible. But the feds clearly had the intent of trying to preserve the systems that states had already enacted for those parts of the market that states regulate.
It sounds like there's a danger of trifurcation here.
Yeah.
Quadrification.
Well, and definitely piecemeal preemption, which is exactly what I would, the issue that I was raising. And we're having a good discussion about that because we still don't know.
Yeah. Now, we do have some questions in the chat box. If I could make sure that we're respectful of the folks that are listening in that don't have a box here. So a couple quick questions, if I could. So the first, this is from an attorney here in New Jersey. I think you said, and I'm referring to Kevin, that the provider payer can seek arbitration. Isn't it mandatory, was the question.
So I'll read. I mean, it could be that they accept the payment that's offered to them off the bat, and if they don't, then they can. I guess that was my point. They can seek arbitration if they don't accept the payment that's offered initially.
But the statutory language pretty clearly is a may at that point, and so we've tried to puzzle out sort of what happens if they opt not to, but I think it amounts to the provider got that payment if they've accepted it, and then no need to incur the risk and the costs that are involved in arbitration.
Second question, excellent presentation. Are the ground ambulances covered in truly emergent situations? And if not, why? Is the patient required to pay the full billed amount of the ambulance or the insurance carrier? I think it's going to the question of that, the application of federal law to ground up ambulances, I guess.
Yeah, the law basically just does not apply to ground ambulances. So it doesn't matter whether it's a truly emergent case or a more discretionary use of an ambulance. Either way, the federal law doesn't apply. The why is tough. Most state laws have not opted to go after ground ambulance services. A couple have, Colorado, Maine, or a couple of the ones that have. I think one of the reasons is that because of so many public sector ambulance companies, county run or city run, I think there's been the politics of just sort of figuring out how to do that has just proved harder. So I think that really is what's happened at the federal level as well. They just felt like they weren't sure whether it just needed to be dealt with differently, and so deferred it by setting up an advisory committee and hope that committee can reach some compromise recommendations. And then of course, Congress would have to jump in and adopt those.
Yeah,
do you guys cover them in New Jersey, or?
It's not clear, but I think the answer is no. I'd see if anybody disagrees. And I think for the the reasons, Jack, you've talked about, it's very, these are often volunteer or local government units running them. It's a different kind of provider with a different kind of politics and payment structure. So, I do think there's merit to addressing it for consumers, but perhaps in some different fashion. But no. I'm going to follow up here on another question. I know we've got 7 minutes left. So follow-up question, but if you're not happy with the payment, is the ADR arbitration process does sole recourse, or can the provider sue in court? Good question.
So the settlement, the intent of the law is to go into what's first a voluntary negotiation, so a 30-day voluntary negotiation period, and then the arbitration, the independent dispute resolution process. The decision of that independent dispute resolution process is binding. So there are very limited instances if there was a something going on fraudulently or whatever, where you could go off to court. I would have to go back to the statute and see if it specifically prohibits going to court in lieu of opting for arbitration, but that was certainly the intent, that these things would be settled preferably by voluntary negotiation. And if that was unsuccessful and the parties weren't willing to take the initial offered amount, then go to this arbitration process. So that's certainly the intent.
Yeah.
But I'd go back to the
I mean, what is clear though is the provider couldn't turn around and balance bill, right? So that's definitely prohibited. And then, I think we would probably have to look back, Jack, and it's a good question.
Yeah.
I mean, there's a long history of, payer provider disputes finding their way into the court system and, out of network stuff. So it's a really good question.
Can I just comment on something Jill or someone said before, just that this is maybe it was Peter, this is an outlier issue, right? That's what prompted the New Jersey debate on balance billing. we have heard that nationwide, right? Like that generally providers, issuers make a reasonable payment, and providers, most of them take it and go. And there's a very few small percentage of providers, and very often, at least recently, backed up by private equity that then end up using this as a business model. And so, in some cases, I think we will. We're going to see, how that pans out. But this bill probably will, potentially not, not lead to more than addressing those particular outlier providers that incorporate this as the business model. So just wanted to kind of follow up on that comment from Peter.
That's a good comment. We don't have any more questions in the chat box. The one thing that I maybe like this a last question, and I think you touched upon this, Kevin, but I was looking for a little bit greater clarity. And this came up in New Jersey's application, is the how you determine the consumer cost sharing as if it were in network. Sometimes that's related to the charge, but where the charge is in dispute. It sounded like the federal law had a solution for that. Could you state that again? I want to get greater clarity.
Yeah, Jack, do you want to? It's a data question, so you might be able to kind of explain it succinctly.
Yeah. So the federal law says that the cost sharing amount should be determined. If it's a copay, then it's pretty straightforward. It's whatever the copay is in your particular plan. But if it's a co-insurance, or if it's a question of what's paid under a deductible, then the idea is it would go by the recognized amount, and that's either the qualifying payment amount, which is effectively the median in-network rate for that insurer for that situation, or the recognized amount can be the amount determined under state law. So that's one of those areas where, sort of similar to Jill's question, there may be some things to be worked out. So we know in some states, they have a particular provision that says exactly how you define the amount under the state law. And so if it's a recognized state law, then that would apply. If there are some ambiguities in the state law, and there may be situations where it reverts back to that federal rule. We've also heard that there are situations where, that median in-network rate, which is actually the in-network rate defined in 2019 and then inflated forward, may be somewhat different than the 2021 rate or the 2022 rate when this was in effect. Mm-hmm. And if the 2019 rate inflated forward is lower, then that's what the law sort of had in mind. But we've heard instances where maybe because of negotiations, the plans actually negotiated lower rates than 2019 inflated forward. And then it seemed like the law specifies that 2019 inflated forward as the basis for cost sharing, even though that might lead to a higher cost sharing than if you just paid it out based on your current rate. So there's some areas that rulemaking may have to clarify when you get down in the weeds of those issues.
Yeah, and it's important to note, though, that would only, like if a state had, a payment standard approach, like in law, that would only apply to the fully insured market. It wouldn't extend to your self-funded market.
Yeah. So I'm mindful of time. I see 9:58. So Jack and Kevin, I really want to thank you for coming and spending your time with us here on a Friday, and Jill and Peter for our expert reactor panel. I really appreciate you guys helping us out. And with that, I will hand it back to the South Jersey Chamber for the closing.
Hi, thank you so much. Thank you to Ward, and a huge thank you to Kevin and Jack. That was a really great presentation. We really appreciate you being here. Just a reminder to all of us who joined, you will be receiving a survey when we conclude. So if you can take a moment and complete it, it'll let us know what your thoughts were of today's event, and your feedback will really help us in our programming as we move forward. So with that, I want to thank everyone who joined us. I want to thank our sponsors, including Horizon Blue Cross Blue Shield of New Jersey, AmeriHealth New Jersey. Oh my God, my dog is telling me we got to wrap up. Inspira, Samaritan Health, and We Work for Health. It wouldn't be a Zoom call unless there was a dog chiming in. So thank you, everyone, and enjoy the rest of your day.
That's great. All right, thanks. Thank you so much for having us.